Happy to be back here on CE Presentation Day. As the screen says, in case you are joining in and your screen is not shared, or you are multitasking right now and have not had a chance to look at the screen, there is a content notice I'd like to give regarding this training. This is going to include things like discussing anatomically correct language and open discussion of sexual behaviors. So please be mindful of your surroundings and ensure any kind of privacy that you may need to, whether that be headphones or anything like that. So I know sometimes we are tuning in from our facilities or maybe at home. And I just want to make sure that you guys are prepared for the discussion ahead. All right. So our topic here, integrating sexual health into mental health practice. This is a topic I'm very, very excited to present. Before we get started, as I said, we are going to be using anatomically correct language, ensure the privacy if you should need so. We're also going to be talking about how sex is an important part of people's wellness. And in that, we should be keeping our clients' values and their expressed needs at the forefront of our approach and meet them where they're at. And so with that, I'm going to ask you maintain a position of curiosity over judgment throughout this training, remembering that we are consistently looking for a person-centered approach to our care. Now, this topic can feel uncomfortable for some people with your own beliefs, or it might be kind of giggly, and that's okay. But please remember that this is a work-sponsored training and that we should maintain our level of professionalism. We can have fun with it, but at the same time, there's a way to have fun with it and be professional about it. I'm going to give a blanket statement right now because I could say this on every other slide, but instead of doing that, I'm going to give a blanket statement now, and I'll give a blanket statement at the end to please be utilizing your supervision when it comes with any of these topics. And also, so that we are all aware and we're on the same page, this is not a training about LGBTQ, and it's not about clients transitioning, any kind of those topics. That's not what our focus is on today. So if that's something that you were looking for, I just want to give you a heads up that those topics deserve their own dedicated time slot. And so that's not something that we'll be talking about in the rest of this training. So our objectives are going to be to describe the link between sexual health and overall mental and physical well-being, define key vocabulary between sexual health and sexual behaviors, differentiate healthy sexual expression versus problematic and harmful behaviors, and then learn how to initiate and navigate conversations about sexual health and history in a trauma-informed manner, and to recognize the unique considerations with the LTC and IDD populations as it pertains to sexual health. All right, so to break the ice, I will watch this quick video. And I can see here that you guys cannot hear anything. I don't hear anything. So, give me just a second here.
I can hear it if that helps.
Perfect.
Same.
Which is good, I think. I don't know. Is it good? It's good. You know what? It's good unless the senior citizens are your grandparents. Then it's weird. It's interesting, though, because this is not always the case. So in the interest of science, farmers market here at the Grove, we asked seniors who gather there. There are a lot of seniors that spend the day there to share their secrets to success when it comes to doing a little something called IT.
We're talking to people about a study that just came out saying senior citizens are having sex now more than ever. What's your secret?
Who said that?
Everyone's saying it.
Not me. Not me. Good luck to them, man. More power to them.
Well, I'm going to be 80 this year, and I have a boyfriend who just turned 83, and I have to say our sex life is great.
What's your big move?
What do you mean big move? I'm not telling any secrets.
Seniors are having more sex than they've ever had. What's your secret?
A little vodka couldn't hurt.
What is our secret? Well, you're not going to get pregnant.
If you do get pregnant, are you worried you're going to have a 30-year-old? What's the best way to get somebody into bed?
You ask too much. I can't answer.
Oh, it's a secret.
Not for me anymore. I did my job, believe me.
Well, I'm not bragging or boasting, but when I was on the bottom, let's see how I get it. When I was on the bottom, I was a Superman. When I was on top, when I was on top, I was a Minuteman. On top, I was, I'm getting mixed. With me on top, I was Minuteman. With me on top, I was Superman. When I was on the bottom, I was Superman. Minuteman. On top, Minuteman. Well, when I was on the bottom, I was Superman. On top, Minuteman. That was the truth.
What advice would you give to seniors who aren't having sex?
You have to use it, and if you don't use it, you're going to lose it.
And you're using it.
Darn right I am. I just did it today.
You just did it today?
Yes.
And who's the lucky lady?
My wife.
God bless you.
Yeah.
What are some turn-ons?
My turn on? A smile.
I like affection, kissing on the neck, holding hands.
I don't have many turn-offs.
That's what I'm talking about.
I don't like rough. Some people do. It's okay for them, but I like gentle, caring, loving. Even if they don't love me, they should be loving.
So some romance, not just a one-way ticket to Pound Town.
Yeah. I mean, Pound Town is better than nothing.
All right. So like I said,
When you pay rent with Built,
wanted to
your
break
invaluable
the ice
points.
there a little bit. Over the next couple slides, I'm going to ask that you put in the chat some ways that sexual health benefits us mentally, emotionally, socially, relationship-wise, and then physically. So kind of throw those in the chat. I'm going to talk for a few slides, and then I'm going to kind of look over your guys' responses before I get into what those are. So according to the World Health Organization, WHO, they define sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality, not just the absence of disease. And achieving sexual health requires a positive and respectful approach and the freedom from coercion, discrimination, and from violence. So for sexual health to be attained and maintained, the sexual rights of all persons must be respected and protected and fulfilled. And this broad definition supports integrating sexual health into routine behavioral and medical care, right? Emphasizing the overall well-being, not just the absence of illness, underscoring respect, safety, voluntary engagement. It also includes the right to pleasure and protection from violence or discrimination. And it ties sexual health to the recognition and fulfillment of rights of all individuals. So that's how WHO defines sexual health. If we were to ask the American Association of Sexuality Educators and Counselors, they view sexuality as inherent, essential, and beneficial to the being of human. And they believe healthy sexual activity must be consensual, self-governed, and free from harm. It is also freedom of sexual thoughts, feelings, and fantasies to engage in self-pleasuring or consensual shared experiences, and the ability to act with responsibility, behavioral, emotional, social, and ethical, all of those in combined, right? Again, put in the chat the ways in which sexual health benefits us mentally, emotionally, socially, and relationship-wise, and then physically. So sexual health and mental health have this bi-directional link, right? Sexual difficulties can worsen mood and vice versa. Difficulty with mood can then impede on our sexual life as well. STIs and HIV risks and the prevention, these are part of routine primary and behavioral health care. So why would we not also be talking about a client's sexual health as it is relevant to their treatment? Screening for trauma and safety and intimate partner violence and coercion where indicated. And I'm now, you can go ahead and keep putting some in as you think of them. But Kim, can you let me know what the chat is saying?
Sure. We have a lot of connection, multiple people.
Cool.
Said connection, human connection. Other people are saying stress relief, decreasing stress, increased oxytocin. Somebody said exercise, good for the immune system, increases good brain chemicals, improves self-esteem, feeling attracted, wanted by someone. Again, a more emotional connectedness. Maybe helping heal from past assault or trauma or other abuse.
Yes, absolutely.
Feeling loved, human touch as it applies to physical and social, building self-esteem. So a lot of connection, a lot of feeling loved for sure, but lots of other ones in there.
So starting with the mental and emotional benefits to sexual health, reduces to stress and anxiety reduction, right? The sexual activity releases endorphins and oxytocin, which then promotes feelings of relaxation and happiness, thereby reducing stress and anxiety. A natural mood enhancement, it can elevate mood and decrease symptoms of depression by boosting serotonin and the dopamine levels. And then increased self-esteem, right? A positive sexual experience can improve body image and just our overall satisfaction of self. Socially and relationally, it creates stronger relationships because sexual intimacy helps to strengthen those emotional bonds, enhance trust, improve communication with your partners, all leading to stronger relationships. So all of these things that you guys have said in the chat and then some, right? And then a fulfilling sex life is linked to increased life satisfaction and a better quality of life because it's creating a positive feedback loop where better sex leads to more happiness and a happier life and relationship allows for better sex. Some physical benefits to sexual health, it can help improve cardiovascular health, with contributing to a healthy heart. It enhances the immune system because a positive relationship with your sexual self is, like I said, associated with a stronger immune system. Sexual stimulation can increase pain tolerance. So natural painkillers like endorphins and oxytocin, coupled with hormonal shifts, like with dopamine, helps reduce pain. Sexual activity can promote better sleep quality because the triggering and the release of relaxing hormones, again, oxytocin, endorphins, and prolactin, and that which induces a calmness, a drowsiness, while simultaneously lowering the stress hormone cortisol. And then speaking on that bidirectional link, though, some physical conditions have a negative impact on our sexual health. So things like neurological disorders, these are conditions such as multiple sclerosis, epilepsy, and stroke can interfere with nerve signals that are essential for response. Endocrine disorders, so issues with thyroid or abnormal levels of hormones like estrogen and testosterone, can reduce libido and affect sexual arousal. High blood pressure, heart disease, and congestive heart failure can lead to sexual dysfunction by affecting blood flow. Things that with diabetes, this can directly impact sexual health by causing nerve and blood vessel damage. In cancer, both cancer and its treatment can significantly affect sexual function and desire and body image. And then pelvic floor dysfunction, weakened or dysfunction in pelvic floor muscles. This leads to issues with urination, bowel movements, and sexual function in both men and women. Okay, so next we're going to talk about vocabulary, right? We need to have a shared sense of vocabulary in order to really move through this training. And I would like to do another little icebreaker here. And we're going to launch a Zoom poll. Now, from the dawn of time, it seems, we have been using slang words to refer to genitalia and sexual activity. And so I have done some digging, and I have found words all the way back from the 1800s that have been used as slang for the penis, vagina, masturbation, and sex. And so I'd like to launch a Zoom poll, and I'd like you guys to tell me, or in your opinion, or which one do you think each of these words is referring to? I will let you know on the next. Do not ask me how it came up with that. I don't know the Latin origin of some of these words. This is just what I was able to dig up on like what are some of the more historical ways or slang that it's been referenced.
I'm crying. These are so funny.
Right, about 40% of you out there. So just to let you know where we're at. We're at 70% of you.
Kim, I'll let you decide when to cut it off.
Okay. Looks like people are still doing it. I'll give them a little bit longer. It's about 10 of you out there. Still need to wrap it up. Couple more people, and then I'll go ahead and end it. I'm going to put the results in the chat so we can all see it at the same time. Okay, Lauren, if you want to keep going, I'll put it in the chat for you.
All right. So I'm going to close out of that. Okay, so the results. Let's see, and wait here for Kim to put it in the chat so that you guys can kind of see where this all lines up at.
So I got my hand raised. So you want me? So I only saw one question to answer, and I only answered the one question,
That's okay. This
and
is
I
more
submitted it.
so. That's okay. It's not a big deal. This isn't graded or anything like that. This is more so. This is leading into a different conversation or a bigger
Okay.
conversation.
Okay. I just jumped in because I thought I heard you say you were waiting for me. Did I? I did not send it.
No, you're good.
I submitted it. Okay. Cool.
You're good.
We got like 90% of you, so that's good enough for me.
Yeah. All right. So here are the words. Now, if you said that clatter devengiance and gimcrack were slangs for the word penis, you would be correct. If you said that quimbo and ringaroo were slang for the words vagina, you would have been correct. If you were to have said that fetch metal and claw were slang for the words masturbation, you would have been correct. And the last, brush and green gown, were slangs I found for sex or intercourse. Now, why does this matter? It is usually from a very young age that we are given nicknames for our genitalia and for our sexual activity. Thingy, flower, nicknames, right? And so the reason that this is worth talking about is because this builds anxiety over the topic. When we do not call things what they are, it builds anxiety over the topic. And this makes people less likely to want to talk about it, even when it is a significant barrier and impact on what else they might have going on. And so that's why I wanted to talk about that, is because I want to emphasize this has been going on since the dawn of time, right? But it has impact, and we should keep that in mind as we are working with people where that discomfort may be coming from. So going on with some common language. So sexuality. So when we talk about sexuality, we want to keep in mind that that it is an aspect of being human throughout the lifespan. So it doesn't stop once we reach a certain age. And looking at this image here on your screen, this can help define our these words here in the color, the red, purple, greenish, and salmon-y color. These help define our sexuality. And then the items in the white boxes on the periphery here are the behavioral ways and that which we experience and express our sexuality. And we want to keep in mind also that sexuality is influenced by the interactions of many different factors that we're going to continue to talk about. So touching on person-centered care, we want to make sure that we're addressing the whole person. And as we will talk more about today, recognizing that the whole person does include the person's sexuality, and person-centered care is dependent on a team approach. And so including the client and their family, if necessary, in that team is supporting and building trust and a trusting relationship with that client. And getting to know the person, finally making sure that appropriate care is readily accessible and that we are decreasing any barriers to that appropriate care. So in person-centered care as it pertains to sexual health, sexual and intimacy needs are met through relationships with others, including family, friends, and long-term sexual relationships. Our identity and our sense of self is shaped and maintained through these relationships, and they become part of our life experience. And the way we express our sexuality as part of our identity contributes to our unique individuality, and that must be maintained throughout our lives as well. So that's how we define person-centered care as it pertains to sexual health. And so the next thing I want to talk about is consent. Again, making sure that we all have a working definition, that we're all on the same page. Consent is a clear, enthusiastic, and ongoing and voluntarily agreement to engage in specific sexual activity. It's communicated through affirmative words, actions, and it ensures that all parties are freely and knowingly participating without coercion, force, or incapacitation. And it can be withdrawn at any time, right? It's about mutual respect, understanding, and ensuring that everyone feels safe and comfortable, and recognizing that silence, assumptions, or a lack of no does not equal consent. And nor can someone consent if they are intoxicated or unconscious. So I'm including this video as a more of a little humorous way to think of consent, but I also am including it as a reference that you can use for when discussing it with clients. So how else could we think about consent as a cup of tea?
If you're still struggling with consent, just imagine instead of initiating sex, you're making them a cup of tea. You say, "Hey, would you like a cup of tea?" And they go, "Oh my God, I would love a cup of tea, thank you." Then you know they want a cup of tea. If you say, "Hey, would you like a cup of tea?" And they're like, I'm not really sure. Then you can make them a cup of tea, or not, but be aware that they might not drink it. And if they don't drink it, then, and this is the important bit, don't make them drink it. Just because you made it doesn't mean you're entitled to watch them drink it. And if they say, "No thank you," then don't make them tea. At all. Just don't make them tea. Don't make them drink tea, don't get annoyed at them for not wanting tea. They just don't want tea, okay? They might say, "Yes please, that's kind of you." And then when the tea arrives, they actually don't want the tea at all. Sure, that's kind of annoying as you've gone to all the effort of making the tea, but they remain under no obligation to drink the tea. They did want tea, now they don't. Some people change their mind in the time it takes to boil the kettle, brew the tea, and add the milk. And it's okay for people to change their mind, and you are still not entitled to watch them drink it. And if they are unconscious, don't make them tea. Unconscious people don't want tea, and they can't answer the question, "Do you want tea?" because they're unconscious. Okay, maybe they were conscious when you asked them if they wanted tea, and they said yes, but in the time it took you to boil the kettle or brew the tea and add the milk, they are now unconscious. You should just put the tea down, make sure the unconscious person is safe, and this is the important part again, don't make them drink the tea. They said yes then, sure, but unconscious people don't want tea. If someone said yes to tea, started drinking it, and then passed out before they'd finished it, don't keep on pouring it down their throat. Take the tea away. Make sure they are safe, because unconscious people don't want tea. Trust me on this. If someone said yes to tea around your house last Saturday, that doesn't mean they want you to make them tea all the time. They don't want you to come around to their place unexpectedly and make them tea and force them to drink it, going, "But you wanted tea last week," or to wake up to find you pouring tea down their throat going, "But you wanted tea last night." If you can understand how completely ludicrous it is to force people to have tea when they don't want tea, and you are able to understand when people don't want tea, then how hard is it to understand when it comes to sex? Whether it's tea or sex, consent is everything. And on that note, I'm going to make myself a cup of tea.
So again, a good way to emphasize the concept of consent, but also a resource to use with your clients if you find so necessary.
Lauren, there was multiple people in the chat just chiming in that they really liked it or they have used it either personally or professionally. So yeah, lots of good feedback on that video.
Good. Yes, it is. This is one of my more favorite videos as well. So let's talk about consent as it refers to capacity. So capacity is a task specific and time specific, and it can vary with activity, with partner, and time. So when we think consent and capacity, we want to avoid all or nothing thinking and check capacity with clients on each different proposed activity and context. So the elements of capacity include knowledge. And to capacity, and this means that they understand that the act or the risk benefits, the acts, the risk benefits, and the protection. So a capacity check might sound something like, tell me in your own words what you plan to do, or what might be the risks or benefits, and how could you reduce those risks? The next element of capacity is reasoning. So that reasoning meaning that they can compare options and consequences. So a capacity check for reasoning might sound something like, what makes this a good choice for you? What choices do you have? And if your partner says no, what would you do in that situation? And then the last element is voluntariness. So voluntariness meaning it is free of coercion. They can say no, and consistent preference. So a capacity check for voluntariness could be, if you change your mind, how would you let your partner know? Or it could be, is anyone pressuring you? So dignity of risk. Dignity of risk is a fundamental human right to make choices and take reasonable risks, even if they might lead to negative outcomes, to live a full, meaningful, and autonomous life. So it asserts that overprotective attitudes, even when well-intentioned, can be dehumanizing, and that self-esteem and personal growth stem from freedom to make decisions and experience the consequences of such decisions. The concept is particularly important in supporting individuals with disabilities, elderly, and those under care to encourage independence and informed choice when it is appropriate for them to do so. And then going back to that person-centered care, it's essential that we are communicating to the rest of client supports, those paid, and if necessary, the unpaid, not just the facility staff or the program manager or the DSPs, but to each other, right? If a client discloses to you that they have decided to be sexually active and that's new for them, you should be communicating with the nurse or the nurse practitioner if they are enrolled in those services. Why? Well, because nurses can check in to make sure that they're using protection, and NPs can help address how their mental health and or their meds may be creating a barrier for them. Next, we're going to talk about autonomy versus beneficence. So oftentimes for caregivers, these values are in conflict with one another. It's very difficult on a very practical level to balance autonomy and beneficence perfectly, right? And we often find ourselves struggling between, should I intervene or should I not intervene? Like, which would be best for this person? And for caregivers, especially, it can be a daily struggle balancing autonomy versus beneficence. The context of sexuality is our goal remains to provide that balance between the two. It's not that autonomy always completely wins out, or that beneficence always completely wins out. It truly is a balance between the two to arrive at what we sometimes call an ethically acceptable solution. So autonomy, this is the obligation to preserve a person's right to live as one chooses, self-direction and free from restriction. And beneficence is the obligation to protect others from harm. So if we were to overvalue autonomy, this could lead to harm, to unsafe behaviors, or even a morally questionable environment. It potentially jeopardizes safety of space around others. In Denmark, a Copenhagen nursing home broadcasts pornography every Saturday night, and staff will even order legal prostitutes at residents' request. And this may be a situation of overvaluing autonomy based on how it impacts the other people of the nursing home and the safeguards that they do or don't have in place. Now, if you look at overvaluing beneficence, this could lead to an overzealous prohibition of appropriate sexual behavior. Now, in Ohio in 1999, a court ruled against a man who sued for the right to spend the nights with his mentally incompetent wife The facility denied his request, and the court upheld this due to, quote, the complex legal environment in which we exist. In Great Britain, under the Mental Capacity Act, staff allowing patients with dementia to engage in sexual activity risk prosecution. And this holds true even for married couples. Even for married couples with a partner with dementia. And lastly here, for our shared language, we'll talk about least restrictive and individualized approach. Now, least restrictive meaning that the interventions must interfere as little as possible with that person's rights, privacy, and sexual expression, while still addressing legitimate safety concerns. And individualized, these decisions are not made categorically, right? This does not mean no sexual contact for residents with an IDD diagnosis, but these are person specific. They're grounded in person's capacity, their consent ability, their health status, and their environment. All right, so is it healthy sexual expression or is it problematic behavior? Healthy sexual expression consists of about 6 different factors here. First of all, it's consensual, right? All parties freely agree and they have the capacity to consent. It is mutual and respectful, okay? It's based on equality, empathy, and sensitivity to boundaries. It is private and context appropriate, so it occurs in appropriate settings, and it respects social norms. It's also age and developmentally appropriate as it aligns with the person's cognitive, emotional, and physical maturity. It's voluntary and enjoyable. So it's motivated by curiosity, affection, or intimacy rather than coercion or compulsion. It's non-exploitative, meaning there's no use of power, manipulation, or intimidation. And it is integrated into overall well-being. So this supports positive self-image, intimacy, connection, and stress relief rather than dysfunction or harm. So some elements here, flirting, consensual touching or sexual activity with an adult partner would be healthy sexual expression. Masturbation in a private setting, ensuring cleanliness, privacy, and consent. Appropriate words or gestures, so expressing attraction through appropriate words and gestures. Sex education, seeking education about sexuality or relationships. And then demonstrating affection, hand-holding, kissing, things of that nature. So that's healthy sexual expression. And now we are going to talk about what are some contributors to sexual dysfunction. So sexual dysfunction has, these four can have these 4 contributors here. Some of them I talked about earlier, right? The physiological, neurological problems, cardiovascular, cancer, medications, fatigue, hormone loss, and abnormality. Then we have these psychological, so that could be depression and anxiety, prior sexual or physical abuse, stress, or alcohol and substance abuse. There's also interpersonal relationships, so partner performance and technique, whether a person may be having sex, but it might not be a fulfilling sex life for them. Lack of partner, relationship quality or conflict, and then even just lack of privacy to fulfill those sexual needs. And then there's sociocultural influences, right? Inadequate education, conflict with religious, personal, or family values, and then any kind of societal taboos. And I can tell you, as someone who went to a private school for my freshman year, and then went to public school for sophomore through senior year, it is vastly, vastly different, right? In private school, it was just don't do it. Simple as that, just don't do it. Whereas in public school, there was demonstration on how to put on a condom. So even just what we are exposed to and what our base knowledge is, it's not all shared depending on where you went to school or the family that you live in, and any kind of cultural values that are at play. So there are some medical or some DSM diagnoses that relate to sexual dysfunction. I separated them out here into the male and female subcategories. So erectile dysfunction and delayed ejaculation. This is where men struggle with erections or reaching orgasm, respectively. And then often with masturbation playing a key role in diagnosis and treatment, right? Men might ejaculate fine when masturbating, but not with a partner, and needing more intense stimulation or facing psychological hurdles like performance anxiety, or it might be linked to medication. For male hypoactive sexual desire disorder, this is a persistent lack of sexual interest, thoughts, or fantasies, just disinterest in any sexual activity, including masturbation. For female sexual interest, it is a lack of sexual erotic thoughts or fantasies, reduced interest in initiating or participating in sexual activity, little to no excitement or pleasure during sex, absent or reduced genital or non-genital sensation during sexual activity. It can also include vaginal dryness or lack of lubrication. And the other one I think that is not talked about enough, female orgasmic disorder is difficulty achieving orgasm. Premature ejaculation is ejaculating before like too soon on into the act. And then genital pelvic pain and penetration disorder. So this is a condition that's characterized by difficulty or pain during sexual penetration. And it includes symptoms like a burning sensation. It could be involuntary muscle contractions. It may be a fear of pain. And the causes can be physical, like infections or scar tissue. It could be psychological, like anxiety or that fear of pain, or relational. And treatment often involves a combination of physical therapy, counseling, and treating underlying medical issues. And I see Olivia has her hand up.
Yay, sorry. I was like, totally fine. I was like waiting for you to finish. I was curious on like what maybe some of the differences are between like the hypoactive sexual desire, lack of sexual want, anything like that, and it being a disorder versus like asexuality and getting into like sexual preferences like that way.
So with the male hypoactive sexual disorder, or that female sexual interest arousal disorder, and how that differentiates between asexuality. And for those of you that don't know, and Olivia can correct me if I'm misspeaking about it, but asexuality is not having an interest or desire to have sex, correct? Yes. Okay.
That's a pretty good, concise way to explain it. Yeah. Okay.
So the difference is that it always comes back to, in any diagnosis, is this impacting your social, educational, or occupational functioning? So the difference being for the hypoactive sexual and the interest arousal disorders, the person wants to be interested in sex and they just aren't. Whereas for someone who identifies as asexual, they're okay with not having an interest in sex. Like that's perfectly fine for them. For the other, this is causing distress in some kind of capacity, whether that be internally in their relationship. Does that answer your question?
Yes, no, I love, that's kind of like what I assumed, but having it still be like specifically answered was very helpful. And then someone else put in the chat, can asexual individuals still be interested in masturbation? Lauren, I don't know if you have an answer for that.
And I'll be completely transparent. I don't really either, only because I really focused the content of this training on behaviors, language, and not so much on the more nuance of sexuality as it presents that way. So,
would you like me to jump in, Lauren?
yes, please. Absolutely, Beth.
So, yeah, I think you all answered it well. It really is an individualized diagnosis, and always, and Lauren can say this much more eloquently, and she will in January or February. Before you diagnose any of these, you're looking at a medical disorder. Because you've probably seen ads on TV for erectile dysfunction. So there's all kinds of medical reasons. So first and foremost, you want to rule out the biological components of these. And then the second part is when it gets into the mental health field is how is it impacting quality of life or the distress to the client? And then is that coming through with behavioral health kinds of symptoms? And so any of these in and of itself can look on any extreme behavior scale of being too, intrusive in other people's lives or being not satisfying to their own personal life. And so that's what the clinician is kind of doing prior to giving these diagnosis. And yes, I mean, that's the disorder, the symptoms of wanting to act out sexually does not, like asexual people can have sexual urges and do sexualized things that you would in your category of mind would think are sexual behaviors. But it could be like Lauren and you all just said, it could be for comfort, for all kinds of things. So you're looking for kind of the psychological reason of that. Does that make sense? So, I mean, it's really getting back to the basics of good assessment, good understanding, person-centered care, all those things that Lauren has already kind of said. And then, individualizing that for the person so it stays in the range of healthy practice.
I love that. And talking too about taking that history and looking at it from a medical perspective, as Beth is talking about, a lot of these things can be influenced by medication, right? So like I had said before, with erectile dysfunction, inability to achieve and maintain an erection, but not inability to achieve orgasm, and then like decreased libido, lacking a desire to have sex. So there are some antidepressants that can contribute to any of these types of categories. The things like your Celexa, Lexapro, Zoloft. We may see these with antipsychotic use, risperidone and clozapine. Our mood stabilizers, lithium, Depakote, Lamictal, those kinds of category or those kinds of medications. Also with benzos, Xanax, Klonopin, Ativan, and Valium. And then opioids, whether they're on Oxycontin, Loratab, and morphine. There are other medications that are for general physical health reasons, but I tried to stick to our mental health medications that we would more commonly see. Now, you guys are going to be getting at the end in an email, I have a list of more specific medications here and like the drug class and an example of that and what the mechanism is as to why it affects it the way it does. So for example, with erectile dysfunction, with opioids, it suppresses testosterone and sexual reflexes. So you guys are going to get this handout at the end. And now another classification here of DSM or disorders as it relates to sex and sexual health are paraphilic disorders, okay? It is important to note that paraphilic disorders consist of non-consenting persons and have impact on the person's social, educational, or occupational functioning, right? So voyeuristic disorder, this is when somebody gets arousal from observing someone undressing or in a sexual situation without their consent. Now, there are people that enjoy watching other people have sex, and as long as the parties are consenting to that, we're not looking at disorder. We're looking at preference or kink or whatever you want to call it. But again, it has to do with that non-consenting person. So it could be like if you think of like peeping toms, right? That would be a voyeuristic disorder. Exhibitionistic disorder, this is arousal from exposing one's genitals to an unsuspecting stranger. Frotteuristic disorder, this is arousal from touching or rubbing up against a non-consenting person. You may see this, I think that this is a real issue in like China, Japan, where like the trains are very, very crowded, where people fall victim to this this violation. That's what I'm trying to say. Sexual masochism disorder, this is arousal from suffering or humiliation of oneself. So that's where I go back to, so if you are suffering, if the person gets aroused from suffering or humiliation of oneself, and that's where it goes, well, is it impairing their social, occupational, or educational functioning, right? And is it to an extent where it could be physically harmful to themselves? That's when we're looking at disorder territory. And then sexual sadism disorder, this is arousal from the suffering or the humiliation of another person. And so what these have in common here, that these problematic, what these are made up of these problematic sexual behaviors. So there's the lack of consent, right? One or more parties did not or could not consent. They are coercive, forceful, or manipulative. They may use threats, deception, or pressure. They are public or invasive, so they disregard privacy or other people's boundaries. They are age or developmentally inappropriate, so this indicates exposure to trauma, sexualization, or impaired judgment. Can also cause harm or distress, whether that be emotional, physical, or psychological harm to self or others. They are compulsive or impulsive, meaning they interfere with functioning or are driven by an unmet emotional or psychiatric need. And they may reflect a power imbalance or exploitation. So this could be between staff and resident, could be caregiver and client, it could be adult minor, but some kind of power imbalance. So sexual manipulation, right? Use of sexuality to manipulate staff, peers, or caregivers. Unwanted sexual contact, like I said, non-consenting touching or sexual contact. It could be with individuals lacking capacity to consent, so people with advanced dementia or an intellectual disability without comprehension. This may look like stalking, harassing, or explicit comments, sexually explicit comments to an unwilling person. It could involve public masturbation and sexual activity in public or communal areas, masturbating in front of others. And it could also be excessive pornography use, right? And again, this is pornography use that interferes with our daily functioning or involves illegal material. And so I want to play this video here regarding erectile dysfunction and how pornography plays a role in that.
There's a growing epidemic of erectile dysfunction in men, and most doctors are missing the real cause. After 14 years of helping men recover from porn addiction, I can tell you what's really causing this and how to fix it. Let me tell you about a pattern I see more and more frequent in my practice. Healthy men showing up with erectile dysfunction. Their doctors run tests, find nothing physically wrong, and prescribe Viagra. But the medication barely helps. Why is this? Because they're dealing with something called PED, porn-induced erectile dysfunction. Today I'm going to explain exactly what this is, why it's happening to so many men, and most importantly, how to overcome it. First, let's understand what PED actually is. Porn-induced erectile dysfunction occurs when your brain becomes so accustomed to the intense stimulation of pornography that normal sexual encounters no longer provide sufficient arousal. Think of it like turning up the volume on your headphones. Eventually, normal speaking voices sound too quiet. The same thing happens with sexual arousal when you consume years of pornography. Here's what's actually happening in your brain. Pornography dumps massive amounts of pleasure chemicals into your system, way more than natural sexual encounters. This is due to the overly exaggerated, overly stimulating videos or images one can find easily on the internet, and to the fact that they can find any and all stimulating scenarios quickly and easily. Over time, this creates two problems. First, your brain needs more and more stimulation to achieve the same effect. Second, your pleasure response to normal sexual encounters becomes dulled. This is why many men can still get aroused to porn but struggle with real-life partners. The really frustrating part is that most doctors miss this entirely. They run physical tests, find nothing wrong, and prescribe ED medication. But if the issue is brain chemistry, not physical health, medication is just putting a band-aid on a deeper problem. It's like trying to fix a software problem with hardware. It doesn't address the root cause. Here's the good news. This condition is reversible. When you stop consuming pornography, your brain chemistry begins to reset. We've seen countless men regain normal sexual function after just 2 to 3 months of abstaining from porn and masturbation. Many report having the best sexual experience of their lives with their partners after this reset period. However, and this is crucial, if you've been consuming porn for many years, simply deciding to stop isn't enough. That's because porn addiction is a real physical, mental, and spiritual illness that requires proper support and treatment. You need a structured recovery process, accountability, and the right support system to successfully reset your brain chemistry and overcome this condition long term. If you're struggling with PED, know that you're not alone, and this isn't a life sentence. Your brain chemistry can heal and normal sexual function can return, but you need the right approach and support system to make it happen. I've created a free masterclass that shows you exactly how to start.
Okay, of course you did. So if you think about how it's in everybody's pocket, this device here with potentially unlimited access to the deepest, depravest parts of the internet, and it is walking around and it is available to teenagers, preteens, and when that pornography use is exposed early and excessively and freely like that, it's not hard to imagine, it's not hard to see how it creates unrealistic expectations for sex, whether that be the way sex is carried out, whether that be the way your partner responds, whether that be the way your partner looks. And so this is something that is really a struggle for people who have that overconsumption.
This recovery process. Click the.
So if you're in a situation where a client becomes inappropriate with you, right? And this can often be a barrier as to why we don't want to initiate discussion. So let's talk about if this happens with you, right? First, we recognize the problem, right? Asking questions like beyond your therapeutic scope, or you feeling uncomfortable and your own defensiveness about it. So if they're making sexualized comments, innuendos, or persistent flirtation, right? Recognize that it's a problem. Now, we want to respond in the moment when it's safe to do so. So keep your response calm, brief, and clear. We're going to use neutral, non-judgmental language to address the behavior without shaming. Hey, I'm here as your clinician and our relationship is professional. I need us to keep the focus on your care. Or what you just said or did is outside of our professional relationship, I'm going to redirect us back to the topic of your care. Okay. If the behavior continues, consider modifying the interaction. So this may mean bringing another staff member in, reducing the one-to-one unsupervised time or change in the assignment. If at any point you feel unsafe physically, and if at any point you feel unsafe physically, emotionally, or ethically, you would escalate, right? So moving on from that, then we want to document and report. Document, document, document. If you didn't document it, it didn't happen, right? We want to know the date, the time, what was said or done, as exactly as possible, like using direct quotes if you can, how you responded, and then that you informed your supervisor or changed the care plan. So follow agency policy. So this could be emailing your supervisor, letting them know that, hey, this is what happened. This is how I responded to the situation. And then also contacting the incident reporting line if the behavior, and they can help guide you on any follow-up actions, if it constitutes as harassment or assault, and walk you through if this is a situation where it may threaten safety. So your supervisor was already made aware of this because you let them know when it happened. Then we would have the follow-up and prevention. So you would debrief with your team or your supervisor, talk about what triggered the behavior. Was the boundary clear? Is there a plan to prevent reoccurrence? We would consider any additional support or training for staff on managing these challenging behaviors, sexual boundary issues, potentially self-care, and then maintaining ongoing vigilance with boundary issues, because boundary issues will often escalate if they are unchecked. And so if a situation becomes where that feels inappropriate and you do not check that by saying, hey, that's inappropriate, that comment you made is inappropriate, and that is not what I'm here to that's inappropriate for our relationship, for me as your insert here. So checking those behaviors early on can help with preventing them from happening in the future. And we should also take into account too the mental health perspective on problematic sexual behavior. So clients with certain diagnoses, maybe something like a personality disorder or sexual disinhibition and neurocognitive disorders, they may present higher risk for boundary crossing behaviors. Could also be that you as clinical staff, you have extra responsibility to monitor for your own countertransference and maintain clarity of role, right? And when a client initiates any kind of sexualized behavior, this may be a manifestation of an underlying issue. So it could be a trauma reenactment, it could be intimacy dysregulation. So in those situations, getting extra support and supervision with how to navigate that. And as I said before, checking in with your supervisor about navigating protocol for managing the sexualized behavior from clients, right? May that include reassignment, documentation. You don't see them in their room. You have to be seeing them out in the common area or, with other staff nearby. And I remember this was like probably one of the things I learned in early undergrad, in like probably social work 101, to never put the client in between yourself and the door, right? So it should never be door, client, you, right? Because now you have created a situation where you have to pass the client in order to get to the door. So even something just as simple as being mindful of where you are at in the room. And again, not everybody is going to be a threat like this, but if it feels like it is, is a potential for a client or a client has a history of that, then that's something that we need to be made aware of, or I'm sorry, be mindful of and thinking about as we are interacting with them as a own point stance of personal safety. Okay. Next here, we're going to talk about taking a trauma-informed sexual history. So about 60% of sexual assault cases in long-term care facilities involve people with dementia. Alleged offenders include family members, paid caregivers, other residents in the care facility, and victims tend to present with behavioral cues of their abuse rather than verbal cues. Offenders can confuse and manipulate them easily. And although sexual abuse of older residents in nursing home does happen, reported cases appear comparatively in the lower percentages, but that may be unlikely to an undercount to the true number of cases because many victims may have cognitive or communication impairments, making it difficult for them to disclose. It may be physically dependent, or I'm sorry, they may be physically dependent or fearful of retaliation, or they're unable to consent. And many facilities may misclassify or fail to investigate incidents of sexual abuse. So because of underreporting and data gaps, anyone working in long-term care should operate with the assumption that actual risk is higher than what numbers show. For IDD abuse, people with intellectual and developmental disabilities experience sexual abuse far more often than the general population. Studies show that about 1 in 3 adults with IDD, which would be about 33%, have been sexually abused at some point in their life. Children with IDD are also at a higher risk. About 15% have experienced sexual violence, which is 4 to 5 times more likely than children without disabilities. And people with any kind of disability, including IDD, are twice as likely to be sexually assaulted compared to people without. Among women with intellectual disabilities, the rate of rape or sexual assault is about 12 times higher than for women without disabilities. So, and especially that statistic too about a higher rate in children, because we know that sexual abuse that happens in children that is untreated can come out and manifest and acted out on other people when they become older. That is something that happens whether you have a disability or not. So being mindful that those people are at higher risk of that happening to them or have had happened to them. Now that we have some information here about what the statistics are on it, let's talk about how to kind of use that inclusive and trauma-informed language. So these habits here that we're going to talk about minimize any kind of micro invalidations, and it keeps the focus on the person's experience and their needs. It invites the client to teach you their language. So even though we just talked about using anatomically correct language, we also talked about person-centered care and meeting them where they are at. So if they are uncomfortable using anatomically correct language, we would use their language. I would personally check in to make sure that you are understanding that when they use this word, is this what they are referring to? And then from there on out, and I would document that. I would include that in your documentation, that this was the way in the wording that it was used to describe. We would also use gender neutral and behavior specific wording. So words like partner or sexual contact. We would avoid any assumptions about identity, attraction, anatomy, or behavior, and asking name, pronouns, or words that they use for their body parts and their relationships.
Can I jump in here? Because
Yeah.
I know the intersection of using anatomically correct and you meeting the patient where they are, but also your professional ethics, you want to be very mindful of using their terms too often. And like Lauren said, you want to really be transparent that you have their consent. Because imagine you going into your doctor and them starting to use slang words. It's just icky, right? And it's not kind of it within the medical field. And so just a caution that, you know, in the environments we work in, our clients go and say, my therapist said, I don't know, do, re, mi for some anatomical correct thing, and you're off and running to, why did they say that? Especially if you're working with children or impaired individuals. Does that make sense to people? And similarly, like, you know, the pronouns are important, but also pronouns can be a trigger. So if someone is really telling you she wants to be referred to as a she, you need to follow that advice, and not put, if they're really biologically something else. And it's a little disconcerting when, you know, they're saying they're this gender and they have these body parts, right? So that's just, I see a lot of, you know, people on here, and I just want to give that caveat, especially for TBS or TBS supervisors who may not have been like in the worlds that we have been, Lauren and I have been in. So we're in the zone of no complaints, right?
Absolutely.
Does that
Thank
make
you for that.
sense to people? Yeah.
Yes, absolutely. That is a very fine line to balance. And so when a person discloses trauma, we start off by validating their experience, just like any other trauma that may be disclosed. Reinforce permission-based discussion. I'm going to talk here in a couple slides here about permission-based discussion. And we want to avoid any graphic details unless it's necessary for care, right? And this is where we are really, really, really going to want to take that interdisciplinary approach, because this may be something that is more appropriate for the nurse to be going over with them. Say if the trauma happened recently, compared to if the trauma happened, 20 years ago. So in your documentation and collaboration, like I said, you can use with the client, this is how they referred to it, and I clarified that this is what they meant. So record what was offered, accepted, or refused. Hey, you want me to call somebody? You want me, or for you, do you want to XYZ? If they want to, or hey, can I offer you this, information if they don't want it, document that you offered it and that it, wasn't wanted. This may require safety planning. It will always require contacting the incident hotline. So again, it's context, right? Whether this happened, if you're working with somebody who is 70 years old and this happened when they were, a preteen and it was their brother who has been deceased, then that's, likely not going to require safety planning, but it will always require contacting the incident hotline just for that, what am I trying to say? That confirmation and that guidance, because it is a very sensitive topic. And then the interdisciplinary approach, like I had said, if like some of these conversations, if it was recent, it may be and would likely be better coming from potentially the nurse or the nurse practitioner. So some barriers to discussion. Why is this such a hard topic to bring up? What it shares in common between provider and client is fear, feeling unprepared and ill-equipped, It could be personal embarrassment or, fear of embarrassing the other person. Now, as a provider, we may have fear of opening a can of worms. We may be feeling unprepared or ill-equipped, like I'm not taught how to have these conversations. It could also be that it's not part of the presenting problem. So why would I go in that direction and talk about that? That's not even what I'm here for, right? The client may have fear of being judged, breaking down and crying. I know I absolutely hate crying in front of people. Feeling inequipped or ill-prepared, not knowing the right words to use, or they may not feeling entitled to start the conversation. And with avoiding the conversation, and when practitioners may avoid discussing sexual health for a variety of even more reasons. And one of those may be their own personal discomfort, right? If we were not brought up in an environment or have done work to bring understanding about the normalcy of importance of sex in people's lives and navigating these conversations, it can be challenging, despite that we've already discussed that they are important. So some people even struggle just using the anatomically correct verbiage. And then when is the right time to even bring this up, right? Well, that's going to depend on the discipline. The discipline may change. The medical team may be reviewing a client's chart, see that they're on medications that have any adverse impact on sexual functioning, and assess at intake if they're having difficulties. And in the medical model, it focuses on it's a focus on a biological mechanism to this. And the interventions may be more direct, such as education on using lubrication if they're experiencing pain or vaginal dryness. People tend to be more familiarized with the typical Q&A approach when interacting with medical providers. When was the first date of your last period? When was, and it's just that back and forth Q&A. Now, the clinical team, you may require time, more time, and more trust building, because your interactions with the clinical team can be seen as more personal and more intimate. We ask deep questions with answers that aren't so black and white, right? We see this person on a more frequent basis. And so divulging this information to someone that they interact with regularly may cause some hesitation and discomfort. For me, when I was working in private practice, it may be part of my intake depending on what they were in for, right? If they are, having a particularly hard time with their husband, then yeah, I am probably going to ask, more so towards the beginning of assessment, like, hey, what is your sex life like? Is it satisfying for you? But again, if it is not, this is all just going to be contextual. So most, if any of us, right, are formally trained as sex therapists, and if you are, you should have been doing this, co-presenting with me. But there's a hesitancy of some providers to wonder, where is that boundary with our scope of practice? And now for social workers, most in undergrad, and I have also checked with my counselor counterparts as well, we are trained as generalists, meaning we have a broad, adaptable skill set range. We know that we have to look at the person, not just a singular chief complaint or presenting problem, but what's contributing to that biopsychosocial model, that systems, ecosystems approach. So all that to say, for our licensed staff, this is within your scope of practice to initiate these conversations and provide psychoeducation, resources, and advocacy. And I'm going to talk more about those next steps when more is needed. So as an example here, a medical approach to information gathering, right? Have you been sexually active in the last year? No. Have you ever been sexually active? Yes. Have you ever had an STI test? Would you be open to one now? If they have been sexually active within the last year, are you using safe sex practices like condoms and birth control? If on the clinical side now, we have to talk about permission and consent. So just like the consent that we talked about earlier, or that we are teaching our clients, we must also obtain consent to have this conversation with them. So asking them if it's okay to ask them about these topics, client may see this as that we are like giving permission for them to speak about this stuff. They may not know if you're the right person to bring it up with, or maybe no one has ever really even asked them these questions. So first and foremost, you're opening the door and offering to have the conversation if they want. And research studies have shown that clients do not voice their concerns about sexuality and sexual health because they feel vulnerable, shy, and ashamed to ask and would prefer the professional to raise the subject. And just like earlier in the video about tea, just because clients are giving you permission to talk about these topics today doesn't mean that you have a blanket consent to talk about this whenever you want. So this is from encounter to encounter. It's important to be continuing to check in with them about their comfort, their desire to continue the conversation, and their ability to end the discussion whenever they want, especially as we are information gathering. Our questions may start out as general, and then they get increasingly more intimate and specific. So looking at how we navigate that discussion. So first, we want to acknowledge the discomfort. I ask all my patients a few questions about their sexual health. Some may or may not apply to you. Give them permission to respond. You can skip anything that you don't want to answer, and we can pause at any time. Asking them, is this, can we talk about this? Are you okay with continuing this discussion? And if they are, legitimize the problem. Hey, it's not uncomfortable for people with X to be also struggle with Y. So is that something that you find true for yourself? Related to relevancy, being intimate and having sex is a biological need for a lot of people, right? So sometimes when that need is not being met, their symptoms are worse, or sometimes when their symptoms are worse, it's hard to meet that need. Move from less sensitive to more. So you may be moving from, are you and your partner sexually active or intimate, to what does a satisfying sexual life look like for you right now? And remembering that they are in control. Again, you can stop me at any time. I am here for you. If you don't want to talk about this, that's totally fine. And then following back up on it, hey, before we had talked about X, is it okay to revisit that conversation with you today? Now, clients wanting to over-engage in this may be a red flag. So keeping it on the mental health focus aspect and how all of this relates back to their mental health, right? If you notice that they are maybe over-engaging in this information. So in the next steps, we would provide limited information, non-expert information. So somebody experiencing pain or discomfort, asking if they have tried lubrication. That is non-expert information, and it is psychoeducation in nature. And just providing some resources for them, and resources that I am going to supply you with here in a little bit. There may be the potential to refer out, depending on a history of rape or sexual abuse, or if there are any kind of those paraphilic disorders that are coming into play, if they are in severely unstable relationships, or if there are any psychological problems. So you guys are going to get these handouts. These are 2 booklets. One of them is a little bit more medical focused. One of them has a little bit more of a clinical feel to it, but it's just booklets on how to have these conversations with clients, and different phrases that you can use. So we're going to do a breakout room. Not 15 minutes. I wanted 15 minutes, but based on looking at time, I'm gonna say probably 10 minutes so that we have time to come back and discuss. So there is one person is going to be the practitioner and one person is going to be the client. Kim will put in the chat for you what your she's going to put in the chat for you the prompts, and they are clients presenting with more sexual health related concerns. I have 2 medical ones that are centered more around medication. So if you're part of the medical team, and you want to go that route, or if you're part of the clinical team, more about opening up and processing. Try to get 2 scenarios to be practice. Alternate who's the practitioner, who is the client. I mean, help each other out, right? This is why we're here. This is why breakout rooms are proven to be effective, is because we have the opportunity to learn from each other. So if you notice that the person being the practitioner is having a hard time coming up with the next question, feel free to jump in and say, hey, what about this direction or that direction? Okay. Please download the breakout attachment to access it.
Excuse me, we'll give people just a minute to do that. And then here in just a second, you will be sent to a breakout room. I have about 3 to 4 people in each room. And did you say, I'm sorry, Lauren, did you say 15 minutes or are we going shorter than that? 15 is good?
10, please.
Oh, 10, sorry.
Yeah.
Okay.
I know.
All right.
I have high hopes for 15.
Okay, no problem. Yep, go ahead and access that handout, the breakout handout, and download it. And then I'm going to send you all to a breakout room of 3 to 4 people or so for about 10 minutes.
And I have on that handout too, like the slides that we just talked about, that navigating the discussion, the parts of it, and the examples, that is also on that handout for you to reference if you would like.
Okay, so you should all have an invitation to join. Please join, and we'll see you back on the other side. Okay, all right.
All right. So I typically I like to just make this a little bit more informal. Tell me about your guys' experience with this exercise. Was it difficult? Was it easy, like what you got in a groove of things? I'd just like to hear some feedback. A lot of echo from me. Does anybody else hear that?
A little tiny bit. Is your iPad on or no? Okay.
No.
It's echoing.
I do hear it a little bit, yeah.
Yeah. I can go ahead and say some things if you like.
Yeah.
Yeah, in our group, all 3 of them had medication related issues. James, the first gentleman, we thought it was, providing education about the medication, possibly consulting with his doctor, maybe looking at some alternative medication, and just his self-esteem relating to it, and maybe doing some joint therapy between both of them. Now, the second one was the female that was 64, and she was getting the benefit from a psychotropic medication. But what we indicated differently and compared to the second one is she noted the desire. So we were thinking it was more of this maybe an age-related issue, that she just wasn't into the sexual intimacy of wanting to have with her husband, maybe wanting to have the other pieces, but not possibly, because it did say desire. So we just talked about healthy ways for them to maybe look at alternative issues. And going back to James too, the first gentleman, we mentioned that, talking about pleasuring his wife in other ways, but also understanding the negative impact on his self-esteem and those type of things. And the last gentleman, sort of the same as the first gentleman, because he was on for heart medication. Again, a little bit older, 65. But doing some education about the medication, maybe consulting with his doctor, but focusing on his self-esteem and other ways they could fill the void that they weren't feeling sexually intimate, or not able to do it, and maybe show affection in other ways. So.
All right. Am I still echoey?
No.
Okay,
No.
perfect. 1 or 2 more people. Thoughts, experiences on the exercise? Stepping out of your comfort zone?
There were a couple of comments in the chat. Kara shared that it was helpful to have Sarah in their group because Sarah gave some advice based on their experience.
Beautiful. I love that. Anybody
something
else?
Something I just thought of sitting here. I think in the past, like menopause or perimenopause related stuff, nobody wanted to really talk about it. It was like, yeah, you're getting older, that just happens, you got to deal with it. But I think especially like Gen X women and above, like we want to bring that out into like the public conversation. There are things that you can do about it. And you just have to advocate for yourself really strongly or have someone support you to do that.
Yeah.
Because there are just so many symptoms of that we just don't think of. We think it's something medical or something physical, but it's actually, your hormones are just kind of haywire, and you can get diagnosed with some sort of mental health condition when it's actually like hormone related.
Yeah, absolutely. That's all great feedback and discussion. I hope that you guys found practicing that made it a little bit easier or helpful when you may have to go and actually initiate these discussions. So as we talked before, our clients are not exempt from sexual needs, and although the topic of sexual health and wellness may be uncomfortable, it can be more so when a person resides in a long-term care facility or has an IDD. So I want to touch base here on what the difference is between a durable power of attorney and what a legal guardian is. So durable / power of attorney, this is appointed by you, the client, to make decisions on your behalf. For the power of attorney, the permission is to make decisions ends if you become incapacitated, where a durable power of attorney continues even if you become incapacitated. Now, a legal guardian is appointed by the court when it is determined by the courts that a person is unable to make their own decisions. So somebody having a durable power of attorney does not allow you to break confidentiality if you have concerns over someone engaging in unsafe sexual activity. Now, if somebody has a legal guardian and you believe that they are engaging in unsafe sexual activity, you are able to breach the confidentiality to inform them of this, right? Legal guardians are allowed to know anything about what goes on in session. It may be important at the beginning discussing with them why this may be counterproductive in some aspects to treatment, but in discussing when it is appropriate or when they are informed. But there's always risks when confidentiality is broken, regardless of the context in which it is required to do so. And it should not be taken lightly. So how this can be navigated is if you find the need to do so, being direct and upfront with your client about your need to inform their guardian and why, right? Hey, you talked about this, meeting up with such and such person. I have concerns. I'm worried for your safety. I need to let XYZ person know. Offer for them to be present when you have that conversation, or even better, empower them to disclose that themselves and provide support or clarification throughout the discussion as needed, right? So a lot of times we see like durable or power of attorney in LTC settings and legal guardians in IDD settings. And so there is distinction there about when we have to navigate dignity of privacy and dignity of risk. Okay, I'm actually going to skip this here because I want to touch base on this. So some common issues with the LTC population, erectile dysfunction, vaginal dryness, and incontinence. And some considerations here could be from polypharmacy, some physical support, some adaptive strategies. If clients may benefit from purchasing self-stimulation devices or sex toys, potentially having to advocate for this, talking with the nurse practitioner, and maybe how to go ahead and help them get those needs met. For IDD, some common issues are communication barriers, sensory sensitivities, and a trauma history. So we want to consider using visual aids, repetition, and permission-based language. So I want to show you here some of the handouts that you're going to be getting. That's the breakout room. Okay. So this is one of the handouts that you'll be getting, the lowdown. And this is very psychoeducational. Are you ready for sex? What are STIs? What is safe sex? What is consent? And why is it important? So this may be helpful to use with your IDD population. Same type of content, but more geared towards the older adults. Information here, again, to share with your clients why intimacy is important in older adults. And then the other set of handouts that you'll be getting is from a workbook that I had that was intimate relationships and sexual health. And so this is a curriculum for teaching adolescents and adults with high functioning autism spectrum disorder and other social challenges. So you will notice you don't have the complete full book. There were things I took out where it's like, oh, this is what you need for this lesson. This is what the group activity that you're going to do. So I took all that out and I'm just providing you with more of the psychoeducation material. And again, this could be something that you use with your clients, or it could be something that you use to get yourself figuring out maybe a more appropriate way to bring this information to them. And so it has things on here, successful ways of asking someone on a date, what, you know, things that, good ideas, things that likely to put people off, initial dates, things to say or don't say. There is also things on here of stages of sexual response, some pictures on anatomy, helping them understanding the different anatomical functions. There was one that I really liked, and it was how, oh, here we go. Stages of a romantic relationship, timeline, you know, first meeting somebody 2 to 3 weeks, kind of, you know, strangers, 5 weeks to 6 months, and then has the opportunity for them to create one as well. Like, what is your timeline? Identifying people within these circles that they have, some information on contraceptions. There is one on here about basically it kind of talking about, hey, well, if you want to have a girlfriend or a boyfriend, you know, people want to be with people who are taking showers and who are brushing their teeth and who are wearing clean clothes. And how that plays into their ultimate goal of obtaining, you know, a partner. And then for non-sexual physical intimacy for our people who are in a long-term care setting or people who are in a wheelchair, there is ways for people to obtain physical intimacy without it being sexual contact. It involves like close proximity. It could involve touch that helps communicate a positive and intimate feeling towards someone without the intention or expectation for it to lead to any sexual activity. So could be being within someone's personal space without any touching involved at all. Could be just holding hands, placing hands and arms, or placing your hands on someone's arms or shoulders or their back, cuddling, hugging, embracing. Sitting close enough to allow for light or firm touching on certain body parts. Could be touching heads together, kissing on the forehead, cheek, or shoulders. Could be non-sexual caress and massage, and sustained eye contact. And with the last few minutes here, I do want to show you this video here on this, I guess you call it like social experiment kind of thing, on maintaining eye contact for 4 minutes. I'm going to skip over, for the sake of time, all like the introductory parts of this video. So just so you all are aware, not all of these people are intimate couples. There are friends, there's a mother-daughter situation, there's people dating. So this is kind of people's experience with just maintaining eye contact for like a 4-minute time stretch, and what their response and what they felt from that.
If you love to travel, Capital One has a rewards credit card that opens up a world of possibilities. With Venture X, you earn unlimited double miles on everything you buy and get access to over 1,000 airport lounges worldwide. Capital One, what's in your wallet?
Okay, that's time.
Oh, that was longer and shorter than I thought it was going to be.
How did that feel?
I felt open and awake and connected. Recently, we've been so busy and focusing on our careers, and I just had time to be reminded of all the little reasons why I love you and why I fell in love with you.
Were you thinking about anything during the 4 minutes?
Yeah, it was just memories. It just brought me
Yeah.
back to like the times we've had together and how much fun we've had together and how you've always been there for me and just always looked out for me and taken care of me, and it was just really nice.
I was just thinking that, I mean, how much I really look like you and how much you really look like Nana.
And I was thinking, don't cry. No, 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 no.
I'm sorry. It was weird. Like, I'm looking at you, I'm looking at me, I'm looking at her. I'm sorry. I hope I didn't mess this up. I'm so sorry.
You guys feel like the exercise changed something for you?
It did make me realise, wow, I've got an amazing man. And I don't take it for granted, because I don't think there are many like him.
Did anything come up that you wanted to say to each other?
You make me feel really calm and cared for, and you're such a good person, and I'm so lucky.
I love you, sweetheart. I really think you're the most incredible woman I've ever met. I actually don't even have words to describe you. But I'm glad I'm yours. I love you.
I'm fine. He makes me so happy.
Oh.
She's so beautiful, so good.
She only says that because I look like her, so it's one of
She
those
has a
things.
big heart. She's a good daughter.
Okay. So after that concludes the topic today, I'm going to put the QR code up here for you guys and open the floor up for any questions.
There wasn't any questions, but I honestly loved that video. The mother-daughter, when the daughter was like, I'm sorry if I messed that up. I was like, no, like you did it perfectly. Like I felt like that experience was like super helpful. I wanted to highlight Kana put in the chat, like that would be really difficult for neurodivergent folks. So just everyone keep in mind, like your client, right? Keep in mind like their preferences and like their culture, their needs, and all of that kind of good stuff. So just wanted to highlight that.
Which is
Yeah.
a good reminder to me to also, any of these topics that come up related to sexual health should be followed up on in supervision, always. Yes, so I had cut somebody off.
I say in some cultures, direct eye contact is like something you just don't do. So, like, that's I guess more of a cultural thing, like learning. If you're working with someone who is of a different background, you may have to do your homework, and instead of coming at it from an American centric place, like, oh yeah, this is what we do, that is probably not how they do it. And so if you want to help them, you've got to brush up on what they do in their culture, or have them tell you.
Well, that is all for today. So I'm going to hand it back over to Kim.
Great. Sorry, I'm losing my voice. Thank you so much, Lauren. That was a great training, very interesting and useful information. I did put everything in the chat. Oh,
Sorry. I mean, you guys make all points, and I just want to say thanks to Lauren, because this is a big undertaking topic, and it was not meant to be interventional based at all. It was meant to be seeing sexuality as a normal part of a human development, because as you guys know, in the environments we work in, these things come up and they're seen as negative, and they're not. They're a normative part of health and wellness, and we just need to, we know that there are cultural aspects and gender aspects and trauma aspects. It wasn't meant to say this is the end all be all, but I think Lauren did a great job staying in the lane of what we were trying to accomplish. So, but you're right, application matters and supervision matter.
yes, absolutely. All right. Well, thank you guys. Appreciate your coming today and learning more about
I have
this
a question.
Oh,
yeah.
Hi guys. So my question is, where else can I, because I tried to, and I will admit, I'm gonna just make my disclaimer. I am old school. I'm 65 years old, and this little scanning thing just came out. The Q bar of the scanning bar, and I took a picture of it. I didn't see where I could download to do the survey. So can you tell me? And I'm looking for a link in the chat where
yeah,
I can do
I
the
can put it in there
survey.
again, but you'll also, after this training is over, you'll get an email.
Okay, cool.
With the
That's
link.
it. That's
But
easier.
I can
And-
put it in
and-
the chat too if you want.
for future, you don't need to take a picture. Like when you put it over your phone, it's like a barcode, and there'll be a little, like there'll be a link that it shows up on your camera. And just
Yeah.
click that, and then it'll take you to this.
Thank you.
Thank you so much.
And if you're still having issues, don't hesitate to email me after the training, and we can troubleshoot it for you.
Yep. So I do have a question real quick about the guardian and the power of attorney. So what I'm learning is, because I have a client who doesn't know who her guardian is, and she can't understand. She's so confused. Don't understand where this person came from. I didn't choose it. And so, in listening to this information, would it be that her guardian is court appointed?
So a guardian is court appointed. A power of attorney or durable power of attorney is self-appointed.
Yeah, so she said she has a guardian,
but she just doesn't know who that person is.
She doesn't know. She knows who the person is, but she doesn't know that person personally. So I'm thinking it was appointed to her. So she doesn't know this person. She has a name and a number, but they never answer.
So Kim, is this the person in the LTC?
Yes, ma'am.
Okay. So some guardianships are done through larger agencies.
Yes. Okay.
And she may not have a personal relationship with them. So I would encourage you to reach out to the facility social worker. And if she's having trouble connecting with her guardian, just work through the social worker and ask her to help, because they have contact with them.
Yes, ma'am. And so I'm always trying to stay in my lane and focus on my part, because I study. I'm a psych student and I study psychology. I'm in for clinical psych, so I had to stay in my lane. So, and then yes, ma'am. So there's protocol that says, you know, I want to just stay within my boundaries. And advocacy is touchy here too. So is it clear? Do I need to, because I'm coming out of class with a concern, if this young lady wants to become sexually active, we can't get in touch with the guardian. And so it's, again, I just want to make sure it's within my boundaries to go to the social worker with this concern. And of course, I'll let my supervisor know first.
Absolutely let your supervisor know. And the conversation is Miss Beth, I'm using my own name, so I won't offend anyone. Miss Beth has a lot of questions about her guardian, has been trying to call them, is trying to make decisions about this area of topic. What ideas do you have for me? And or can you go talk to her about what her options are?
Okay, because her concern is she has no contact with her guardian.
That's where you would take it to the social
ma'am.
worker and your supervisor. So, and then, you know, the idea of sexual health and a guardian is, you know, people are going to do what people got to do, and guardians are going to do what they got to do. The issue is like I think Lauren's framework is when it gets into the part of victimization or, you know, bad things happening to vulnerable people, we want to report that.
Yeah.
Okay. Got it.
Is that a fair response, Lauren?
Yeah, absolutely. And, you know, keeping the client informed, I have to let somebody know, and I don't want to do this behind your back. Like, I want you to know that this is happening. I'd like you to be a part of the conversation.
Okay.
And the sticky part of that is social workers are going to be like, what? And then you just kind of say, here you go. Here's what I'm working with the client, and I don't know how to respond. How can we team respond? And they usually appreciate that more than us like going the advocacy route. Because
yes, ma'am.
We know it's advocating, but they think it's something else. I don't know.
I know. I get it.
Great question.
Thank you.
Yeah, great question. Any other
I
questions?
have a question. So I'm looking at this little quiz thing. I'm kind of a little lost on question 2 when it says license associated with license type select in 1.
So those are for counselors, social workers, nurses who are taking this course for continuing education credit towards their license. If you're not licensed, we still value your input. You could just put NA or put nothing in there, and that's fine.
Okay, I was like, because I'm like, I googled what it was, and I was like, that's none of my titles.
Alicia, you're another as a BSS TBS worker. So, and like Kim said, your input's valuable.
Yeah, we definitely appreciate any feedback or other topics that you want to hear about. Please put those on the surveys as well. That'd be great to hear.
Yes. Okay, good. That was it, because I was like, none of these words really pertain to me, but let me see.
Yeah, that ain't me.
Thanks for clarifying. Appreciate that.
Okay, thank you, ladies. We're done.
Yep, we're done.
All right, you ladies have a wonderful rest of the day.
Yeah,
you too. Thank you.
Thanks.